Welcome, everybody. Thank you all for joining us this Friday evening. A very special guest today. So Sarah was part of our group here at Yale before the pandemic. And she was one of the co-leaders of the CASY group way back in the days when it was all in person. So this is all sort of pre-pandemic stuff, 100% in person, no online stuff. So we go way back, and I'm so glad that she has decided to talk to us today. She's out earning her PhD on the West Coast, almost done, and she is very much interested in neurodivergent communities. And her topic today, I think, is very important and certainly very timely. And she's going to tell us what she's learned all these great years since she's left us. But coming back, but not to Connecticut, but to Massachusetts. All right, why don't you go ahead, Sarah?
All right. Well, yeah, thanks everyone. It's nice virtually meeting you. Um, Dr. Joe's going to be sharing a presentation because unfortunately, Zoom on my laptop is not working for some reason. That's okay though. I do apologize, Dr. Joe, that there's animations, and so it might involve multiple clicks per slide, but that's all right. And I'll just, so just the clicking might not always correspond with what I'm saying, just as a heads up to everyone. But if you have any thoughts, there's a few parts of the presentation where I do ask like some open-ended questions. If you have thoughts, please feel free to put them in the chat. I'll try to occasionally look at the chat to see if any questions come up as well on there or any thoughts. I'm a trainee, so I'm always interested in hearing people's thoughts and opinions on these kind of subject matters. In terms of getting the slides, I don't have an issue with it. So it might just be a question of if that's something that we can post on the Project CASY meetup or something. But yeah, so we'll get started then. So we'll go on to the next slide. Yeah, so what are we going to cover today? Broadly speaking, we are going to talk about the neurodiversity movement. We're going to talk about concepts like the double empathy problem, think about important clinical considerations, right? If you are a therapist or you are someone who completes assessments, what are some important things to think about? What are neuro-affirming approaches? What is the therapeutic assessment model? And lastly, we're going to talk about the importance of neuro-affirming language in report writing if you are somebody that completes assessments or reading assessments, interpreting assessments. So yeah, as Dr. Joe said, I am a doctoral candidate who is hopefully going to be defending her dissertation sometime in the near future, research-wise. So when we're thinking about my thesis, my dissertation, and some other projects, kind of the broad focus has been thinking about how caregiver factors and other kinds of contextual factors, for example, other family factors, demographics, how that might relate to informant reporting discrepancy. So I've looked at, for example, how parents report on behavior versus how teachers report on behavior. My dissertation has specifically focused on how parents report on anxiety versus how the child themselves reports on anxiety. And for my dissertation specifically, wondering, can we lessen discrepancy by talking about discrepancy with families? So we can go ahead to the next slide. For next slide, in terms of like where my resources, came from, some of this information, some of the materials, I don't have anything to, disclose at this time, but would like to thank Dr. Ohanian and Dr. Stipa for their mentorship during my training and for some of their resources. So let's see here. Next slide. I also just want to provide the caveat here that for this presentation, I will be using identity first language. Some examples of this type of language might include me saying, for example, autistic person or non-autistic individual, neurodiverse folks. Next slide, we'll get into some specific terminology. Now, real quickly, you might see that we have a visual here that kind of shows an umbrella of neurodiversity. I just want to, clarify or kind of provide a disclaimer that yes, this is referring to the terminology used in our diagnostic manuals, right? So for example, developmental language disorder might be considered under the umbrella of neurodiversity, but this is not to suggest that neurodiversity equals dysfunction. These are just these are terms that are used within diagnostic manuals within the field of psychology. But we can think of neurodiversity as neurological differences that are explained by normal natural variation in human genes. This term was coined by Judy Singer, I believe in the 90s. And right, so it makes reference to folks who have varying neurotypes. Now, when we think of neurodivergence, right, it's very similar terminology, but we want to think about it's basically the unique brain style or unique brain processes that might differ from a neurotypical brain. When we think about neurodivergent, this is a person with a non-neurotypical neurotype. Oh my goodness, that's a mouthful. Okay. So, right, just the idea that not every brain works the same and that each individual takes in experiences or benefits from recommendations, different treatment approaches differently. We'll go on to the next slide here. So a few things to consider, culturally speaking, is we know that the research suggests that there is a greater gender variance within the autistic community, including non-heterosexual orientations. Right, and that's something that is important to consider. Of course, in any treatment context, you want to ask folks about their pronouns. You want to gather that kind of important gender identity information, whatever the person is comfortable sharing with. You do that with everyone, but I think it's especially important to make sure you're considering that when working with neurodiverse folks. I also want to just make note of kind of some of the racial disparities that have been going on in terms of diagnostics, right? So, it's pretty well established in the literature that there are racial disparities in the age of diagnosis for youth, for autistic youth. And right, there's different things that could be contributing to that. It could be lack of potential awareness in certain communities. It could be just lack of maybe what are neurodevelopmental differences, right? And many other contributing factors. I did want to just talk about one study, though, that I found interesting. And this is from 2021, so there very well could be new information out there. But basically, they looked at ADOS scores. ADOS is like one of the forms of assessment. It's like an assessment measure that is used in some cases for diagnosis / assessment purposes. But what the study found, yeah, ADOS, ADOS, that's right, yeah. And so what they found in the study was that in order for the detection of an autism diagnosis, specifically with Black children, there needed to be more of a higher level of support need in order for that diagnosis to be picked up on. In kind of positive news, we do see that that the ADOS ratings did not show consistent racial bias, at least among youth who did ultimately obtain an autism diagnosis. So, I think, of course, we always are looking to do better in the field and consider these things, because this is important cultural stuff that we should be taking into consideration when we're assessing or when we're treating folks. All right, I'm just going to check the chat real quick too, because I feel like I might have been ignoring that a little bit. Yep. Yeah. So, right, people might have personal experiences where it's been a harder time getting a diagnosis. Yeah, we still, right, even though like we think, generally speaking, like within US culture, like I think there's been increased awareness, but there's still a lack of awareness, most certainly in communities. And if you're not seeing the slides, if you're on your phone, it's possible that it's just on a different, you might want to try swiping left or right. It's possible that that could help you see it. We'll go on to the next slide here to start talking about the double empathy problem. So the double empathy problem, I have to just, cite that I got this. I did not make these illustrations. I can barely draw stick figures. So we're very lucky that we have artistic folks out there that can make these lovely animations. This is from the Facebook page Neuro-Wild. And this person, they developed different kind of cartoons to basically like just talk about different autism related concepts. So double empathy problem. We'll go to the next slide. So this person, when they made their illustration, they talk about how squirrels have no problem communicating with one another and making friends with one another. Right. So you see that in the first image there. Right. And then beavers, they have no problem talking to one another. They make friends with one another. They talk about beaver things. And we'll go to the next slide. But when, right, the squirrels and beavers try to communicate, sometimes a miscommunication occurs. Sometimes a misunderstanding might occur. And maybe they ask each other, whose fault is it? Who's responsible for fixing or adjusting? So we'll go to the next slide. And, interestingly, society has decided that maybe it's only the squirrel's job to repair the miscommunications or to make the adjustments. And that's kind of, that feels kind of strange, right? And you might maybe not feel super comfortable with that idea. We'll go to the next slide. And so the person who made this illustration about the double empathy problem, they provided some ways that we don't maybe have to fall into that trap. And they focus specifically kind of on like what you can do with your kids. But, I think this can apply to all folks, right? That we want to recognize that there is a unique communication style that some folks in the autism community have. And it can be related to a mismatch in communication, not necessarily because there is disorder, dysfunction, etc. Right? So like, it's important, I think, early on for kids to learn that about themselves, for that to be kind of internalized, right? That they have just a different communication style, and that they don't have to learn the same way that the student next to them learns. Reminding kids it takes two to tango, right? Communication's a two-way street. It's never just one person's quote unquote fault if something is misunderstood. And making sure, yes, neurodivergent kids should have opportunities to hang out with other neurodivergent kids. So that's the double empathy problem. We are going to switch gears a little bit, and I did want to just provide a little heads up here, and I'm just looking at the chat here. Yeah, still lack of awareness. Yes. That for the next slide, I am going to be referencing topics related to sexual assault and suicidality. And so if you need to, take a break for a few minutes, exit out of Zoom and rejoin, please feel free to do so. But we're going to be talking about, some important considerations here, and we'll go on to the next slide. Yes, I agree with your comment that this is right. We can think about this for kids, the double empathy problem, but then what also goes on in the workplace for adults, what goes on in social settings for adults, most certainly. Okay, so yes, this is some, the literature cites to some ways in which autistic adults can be at a higher risk of certain risk factors, right? So research suggests that that females with autism and ADHD are at higher risk for sexual assault. There's research to suggest that autistic individuals can be more likely to experience heightened rates of victimization, right? That can include bullying, that could be like financial situations being taken advantage of. There's a whole array of what that category consists of. And it's estimated that 70 to 72% of autistic youth have at least one co-occurring psychiatric disorder, right? So they might have generalized anxiety disorder. They might have persistent depressive disorder. They might have OCD. And so I posed to the group, why do you think it would be important? Like, why is this information, knowing this kind of statistic, how could that be useful or important when we're thinking about working with adults in a therapy kind of setting or an assessment kind of setting? And while y'all think about that, this is just another statistic referencing the higher risk of suicidality. Yeah, somebody mentioned it's important for proactive safety, right? Yeah, there's just a lot of things we want to make sure, yeah, of course, that we are continuing to check in regarding risk. That just because maybe someone is neurodiverse, that doesn't mean like, oh, I don't have to ask those questions or anything. No, ask the questions. Ah, yes, this one is interesting. So, um, right, it's not the that problems that somebody comes in for therapy, it might not be like it's about autism, but that autism can coexist with other things that are going on in people's lives. Um, let's see, and then also, yeah, taking into consideration those late diagnoses of adults. Um, let's see, important to be aware and to know so people in the environment can adjust. Yes. Yeah. So it's just, this is great. Basically, in that, like, if we know that folks, when they were growing up, were dealing and navigating situations, right, that might involve higher levels of anxiety, might involve experiencing depression, might involve maybe some compulsive tendencies that were really time consuming or disrupting someone's day-to-day kind of life, right? We know if that higher risk is there for children, that's going to carry on while we treat folks who are adults. Now, let's see, this next slide here, right, is referring to what is neurodiversity affirming care, or the shorter version that I often use is neuro-affirming care. So we think of that as a service model where that takes into consideration and values neurology and neurotype when we are developing care and while we're also implementing care. And yes, autistic wellness can look different from neurotypical wellness. That is a great point. And yes, folks, most certainly, I think that the last comment, most certainly the assessments, my small N sample of assessments that I've done, I think trauma history is almost always something that we are taking into consideration when doing adult autism related assessments. Um, so now let's think about, before we get into assessment, let's just start with treatment, or what we think of as individual therapy. Um, I think just starting with your space can be really important. Just thinking about the space, and does it give people the freedom or liberty to to be their organic selves, to, as some people may put, an opportunity to unmask, not have to have the mask up. And some ways of doing this can be thinking about the space, right? So some folks in therapy, they're all about like having a paper and pen. So while you two are talking together, they can write down concepts. Sometimes they can illustrate concepts, make graphs, make charts. Some folks might prefer using, a sensory kind of related object to keep hands busy. I know, like myself, when I'm doing therapy, I've got my bucket of sensory related objects, and we'll also, along with folks, use them. Asking about light, the temperature. If you have those really like, right now, what I have, the bright overhead light, if you have a lamp in your office, maybe, right? Like just checking in, like, oh, lighting okay? Um, I think a person doesn't need to keep seated when doing therapy, right? It's okay to move around. If folks pervert, some folks have a preference for handouts and worksheets because it provides structure. And so trying to best understand your patient, if that's something that is a preference of yours, you might be more apt to use handouts or worksheets. Talk about appointment times, encourage setting reminders, can be useful for some folks. And then, of course, talking about things that folks are passionate about, things that folks are interested in. This is both to establish rapport and get to know one another, but also, I think, like with starting with preferred interests is a really great entry point into better understanding what's going on for the patient or client. We'll go to the next slide here. Here are just some other considerations, right? So we already talked about checking about pronouns, checking about someone's gender identity can be very important to do. And then I already talk about some interests, right? This gets at also like you as the therapist might want to do some values-based work. And so how do you start with that? You talk about interests, things that people are passionate in, things that bring meaning to people's lives. And of course, right, we as the therapists don't want to sound patronizing. In some cases, being more direct or providing options can be helpful for patients or clients, but that doesn't mean that we have to use a patronizing voice or anything like that. And then, of course, also just consider what those individual differences are in learning, right? So like some neurodiverse patients I've worked with, really prefer handouts, prefer like that I'm showing them a visual while talking about something, or that like life work in between sessions involves a worksheet. Other folks, they don't, they don't get a lot of utility out of the worksheets. So really just, when in doubt, talk to your patient about that. And that applies to whether or not you're working with neurodiverse folks. All right, can go into the next slide here. And I'm just going to check the chat. Yes, treatment modalities. Yeah, I got asked. So, as part of graduate training, you have to submit these essays for applying to internship, which is basically like equivalent is like residency. And they ask you for your theoretical orientation. And I really struggled with that because I was like, what if I don't have a theoretical orientation? What if I just like to use lots of different modalities? And that does exist, but it's a little bit stressful to think about. And yes, so yes, treatments, yep, and modalities can look different. So what might you focus on in therapy? These are just some examples, right? This list is not, does not include all of them, certainly. But right, it might be about learning to self-advocate. Let's say maybe you just recently received a diagnosis. You might want to better understand kind of what your options are in the workplace, or for example, like what your options, even talking to family about autism, what might that look like? Thinking about some folks might want to better understand their identity, right? Well, like what was the process itself of kind of going through this diagnostic journey? And I think that can be important to process and explore in the therapy context. Um, some other potential areas of focus, which we can do one click and it should just stay on the slide and suggest a few other things, is thinking about executive functioning, right? So some folks might be like, I really struggle with making decisions. I really struggle with keeping a calendar. Forgetting that I was supposed to go meet up with this friend the other day, I just completely forgot. And right, like those things most certainly can be talked about in the therapy context, and thinking about what might be some useful compensatory strategies. Stress management. We all have a lot of stuff going on. When in doubt, you can always focus on stress management in therapy. Self-acceptance, right? And I think that goes with also like the self-advocacy piece. Talking about building meaningful connections, right? You never want to assume that a goal of someone who is neurodivergent might be like making more friends or going out and doing XYZ. But when you start to talk about values, when you start to talk about things that are important to the client, you will get a better understanding if that is something that they're interested in. And you can talk about it, you can ask about it to see if that is indeed a treatment goal of theirs. All right. We will switch over to the next slide. And yeah, I'm just looking at the chat here. Yes, right. So we don't want to think that somebody is just being non-compliant or maybe like giving you purposely a hard time just because there might be some challenges or roadblocks that come up with recommendations or certain types of treatments. That's awesome. Yes. And then thinking about make the goal of rediscovering stims and sensory joy. Yes. Right. So just another reason to have that basket of sensory objects. Unfortunately, some folks who are now adults may have received the messaging as children that any type of stimming was not allowed in the classroom, or, told to keep your hands still, sit down. And yeah, therapy can be a place where we can unlearn some of those things. All right. Language, right? I know I mentioned in the beginning of the presentation that I was going to mainly be using identity first language, but I did just want you to know like that and you likely already know that there are other forms as well, person first language. When in doubt, I always just check with my patient or client, because like some folks, I've learned some folks, they are like, yeah, no, I use this language. Thanks for asking. And then some other folks, they're like, oh, I haven't really thought about it. Like, what is that? Like a lot of times I get like, they ask me like, what do you mean by language? And I can explain that of like, this is something like in the autism community, these are kind of things that are thought about or considered. And, so, and with you, maybe they just had a diagnosis with you on your autism diagnosis journey, like you for yourself can kind of, figure out what makes sense for you. I include some visuals there. I just like some of those cartoons that basically depict the different versions. And fortunately, the APA, because for a while, the APA was only using person first language, right? Which self advocates, I think made a good case for why the APA needed to make some changes. And so, as far as I'm aware, that's the most recent revision, but please someone correct me if that is not the most revised policy that the APA is going with, which is basically like use the language that is appropriate for your audience, I think is basically how they are conveying it. And right, like some folks that could still potentially be problematic. Like some folks may not agree with that as well. I think it's something that I've just heard a lot of different opinions on from lots of different folks. So just keeping open-minded about that. And we'll go on to the next slide here, where I would love to hear folks' thoughts about how a psychodiagnostic or neuropsychological assessment, right? So just think assessment, maybe the question being, do I have autism? How could that process be potentially therapeutic to a client?
Maybe because like if we're like saying like, yeah, it's not just me. It's like like yeah, sometimes it's like why am I this way? Like what's wrong with me? And like knowing like what exactly you know what you have, and then you can get treatment for it, or meet other people have the same condition, or yeah.
That's a great point. Yeah, thank you for sharing that. It's like, it can be a way to connect with community. It can be a validating experience for folks. I'm seeing in the chat here, oh, you get that aha moment. Yes, you love when the aha moment happens at feedback. Let's see. Answers to lifelong questions, knowledge, and knowledge is power. Interesting. You say knowledge is power. That phrase is literally on my next slide. Right. People are thinking it's a personal shortcoming, but then you learn, no, this is actually like my brain style. Right. This is my unique brain style. Access to services, right? So again, that connection with community, getting to unpack memories. That's interesting too, right? You are providing extensive background information, and possibly elements of that could be therapeutic. Okay, and then like going to a conference was really helpful as well. Awesome. Yeah, thank you everyone for answering that
So
query.
we have
Yeah.
someone with their hand up.
Oh, yeah, great.
Sorry, was that I think those did you want to say something?
Oh yes, I'm sorry, I was on mute. No worries. Thank you. Hi, I figured I'd answer verbally rather than type. It's faster. Great. It can be therapeutic in a very literal sense, meaning you might be suffering from depression, and when you realize you're autistic, so many of the things you were doing that were leading to a depression, you stop doing. Such as masking, obviously, but such as having expectations of yourself that don't match your neurotype, or um, living life and setting up life in a way that's not overwhelming or exhausting, and so on. So it can be actually literally the solution to a therapeutic need, such as a depressive situation. Thank you.
Yeah, no, the excellent points. And I think someone in the chat just like mentioned a term that can be used to describe can be used for what you were describing, autistic burnout. That is a phrase that references that idea. Yeah, no, that's great. So yeah, lots of different reasons as to why assessment can be therapeutic, right? Now, that's not to say, of course, like there could be times where maybe folks have negative assessment kind of processes. My hope is that as we continue, you know, utilizing neuro-affirming approaches, that folks don't end up having those kind of invalidating experiences, and that this is an experience that is validating. It's for me personally, like the reason why I enjoy doing these assessments so much is because I get to just see folks have answers that they've been looking for. And I think that's really, for me, that's personally meaningful. We can go on to the next slide to talk a little bit about the therapeutic assessment model. So underneath this idea or this model is just some more words: collaborative therapeutic neuropsychological assessment. That's like a specific type of framework when doing assessments that was coined by this person in 2008. And so, as somebody said, knowledge is power. Basically, how this like framework thinks about it is, right, like we want to expand our role from a purely neuropsychological technical view to a more holistic endeavor, seeing the person as a whole, taking into consideration all of the contextual variables around them. Right? And we want to think about testing as intervention, right? Having that transparency throughout the assessment, being like, I'm wondering if we should add this additional measure because you brought this up. And I think it could be useful for us to better understand maybe what's going on there. But what are your thoughts? And then feedback sessions, right? So once an assessment is done, the data is synthesized, the report is written, you would likely have a feedback session with the person who did the assessment. And it is, I think the feedback session itself can be set up in a kind of fashion or format that folks can find therapeutic. And I'm seeing that there's just some things in the chat, so I'm going to take a quick look. Yes, more info on autistic burnout. How do you manage the conversation if when someone thinks they're autistic, seeks an assessment, but the test says they're non-autistic? Oh, yes. Okay. I'm afraid, yeah, because what if that could be an invalidating experience if, right, the test results say otherwise. This is great. And I have to let you know, the majority of postdoc interviews I did a few months ago, like I got asked that a lot. Like, how would you go about that? How would you talk to the client about that? And so I think it's a good idea before even the assessment starts is to have kind of like a therapeutic conversation about like, what would it be like if the test results say otherwise? And additionally, talking about how something on a piece of paper, right? Like there's still like the capacity for people, I believe at least, or this is my kind of like the way I think about it, like for people to self-identify however they want to identify. I think what is important is about like finding your people, like finding community, finding resources, finding places where you get that feeling of meaningfulness and belonging. And right, though maybe the assessment, the specific data that was collected during that specific assessment period is not enough evidence to provide one of those kind of clinical diagnoses. Folks self-identify, and that's cool too. So let's see here. Oh, why is IQ testing? Oh, I love that question too. Such great questions. Why is IQ? Yeah, 90% of it was IQ testing. Okay, yeah, I can answer this. Well, I think when I think of a battery, I'm not putting a lot of emphasis on the IQ testing. There's a few reasons why folks may include IQ testing. One of them being, or there's two reasons. And these are, again, just keep in mind, like these are patterns, these are averages, but oh, yes. And the last comment, very interesting, right? Like it's a potential indicator that you're not exhibiting distress, that maybe what you're experiencing doesn't necessarily yield what the clinical psychologist might say, quote unquote, functional impairment, right? And so that could potentially affect results as well. Yeah, that's really interesting. Yeah, real quick on the IQ thing. So some things I'm looking out for if I decide to do an IQ test would be we can sometimes see that there are differences in processing speed and working memory for autistic individuals. So I always just kind of like to look at those broad indices. Additionally, we also know that this cool thing can happen where some folks have really awesome personal strengths in verbal abilities, or they might have really awesome personal strengths in nonverbal abilities. And I know, I think maybe there's that stereotype or generalization that autistic folks, it's always about puzzles and visual learning. But no, kind of what we see is it can be kind of either, can be a personal strength. the verbal or the nonverbal abilities. And so if I see that split, again, it is not enough evidence at all to provide a diagnosis, but I think it can be a helpful component or just another little piece of information. Okay. We'll go on to the next slide here. Okay, offering recommendations. So, right, the end of a report should always include, right, what do you recommend? And for me personally, I think it's important to talk about the concept of neurodiversity. What's the neurodiversity movement? Encouraging clients that they should be doing their own research and figuring out, kind of like what beliefs or values they want to affiliate with or they feel makes sense for them. And you can provide examples of resources, which I have on some of the next slides. And then, making sure that your recommendations aren't suggesting that someone try to be more neurotypical. Avoid using language like client should do this because, it's not really up to us. And then thinking about providing resources, so like, for example, if I have like a patient that's like, I'd like to know or I'd like to think about more how to talk to my partner about my autism. Like I might specifically be on the lookout for some resources about partners talking about autism. Let's see. I'm seeing that there are more comments in the chat, and I think maybe we'll get through some of these resources and then I'll look back at the chat to see if there's any questions I can answer or anything like that. So these are just some books and online resources that I have used in the past in my recommendations sections. I always provide the caveat, right, that like these books often include like the experience of individuals, folks who may have received diagnoses later on in life, folks who may have received diagnoses as children, folks who may self-identify, right? So again, it's important like that these are going to be the opinions of folks. These are going to be the experiences of folks. And, for you to gather the information that you want to gather from these resources. The next slide is going to have some video resources, most of them being autistic folks talking about different experiences, patterns of behavior, ways of thinking. There's a fun, I think it might be not positive, is do all autistic people think the same? And they have folks, they do this like with a ton of different types of like social commentary topics. But they have folks kind of like put themselves on a line from like strongly agree to strongly disagree to just kind of see where people from different communities land. So that one's pretty interesting. And then we'll go on to the next slide here where we're going to talk about neuro-affirming language in the report writing. Yes. So yes, again, like there's similarities, differences, everything in between when we're thinking about the autistic community. Yes. So that accommodations, that there could be a stigma around accommodations. That is certainly, something I think, or like what immediately comes to my brain is right, like whether to talk to your employer or not about your assessment report. I'm never going to tell a patient or a client what they should do in that case. If they choose that they feel that their work setting is a safe enough, affirming enough place where they could talk to employers, where they could talk to like a union advocate, then I think that there can be certain supports put into place in work environments that may be helpful for some folks. The potential risks of getting a diagnosis on paper. Yes. Okay. I like hate that we have to think about that. As of right now, this information is protected under HIPAA. And as of right now, HIPAA cannot be violated for some type of outside organization or institution to access. So I would say for now, I guess I personally haven't thought of that too much, though it has more recently crossed my mind. If it's something that is a concern of yours, I think definitely like having the conversation with the psychologist that you're working with or the assessor, and like fully understanding like the terms of confidentiality. Let's see. And then assessment, can it capture all neurodivergence for low support needs autism? I think there is continued consideration of that. Some of the measures that we use, I think, well, we know that they are very male based. A lot of the research on these measures are utilizing norms and data from male samples. So, yes, I think like the measures themselves are not always picking up or detecting. And then the case of for folks with low support needs. I have been trying to incorporate a survey, the CAT-Q, that gets at kind of like, it's a measure of masking. And I find that really interesting because like some people are like really good, strong maskers. And I think that could also potentially affect kind of like your conceptualizations. So I've started using, CAT-Q, yeah. And the great thing about that is they have non-binary norms. Whereas some of the other ones, I have to say, Pearson or whoever, the company, whoever makes these norms needs to get on it. All right. So I recognize, time. So I'll just go through this quickly here. But these are just some examples of maybe like language, right? You're an assessor, you're writing a report. Here are some things that you might want to consider, right? So instead of deficits, how about differences? Instead of RRBs, how about recurrent movements? How about routine behaviors? Instead of rigid, what about the person thrives when events are predictable? Or maybe this person struggles when expectations are not compatible. Or this person's best able to engage when discussing areas relating to things that they're passionate about. Right? They might have an acute sense of smell that could lead to sensory overwhelm, right? Whatever that, whether it be smell, touch, problems understanding sarcasm, right? Maybe sarcasm poses as a challenge because there's a preference for direct and explicit communication. Restricted interest. How about deep passion or deep interest, deep knowledge, or this being a regulating activity? Okay, I think we can go on to the next slide here. And write this language, like this is not, I bet there are like tons of other also wonderful forms of language and options of language to use. Those were just some examples that came to mind, some phrasing that I use in my writing, but definitely would love to hear other people's thoughts on that. And I believe that is it. The rest of the slides are basically references. We have a request to go back to the slide about neuro-affirming language, which we can definitely do. And yeah, I know we have a couple of minutes, so I'm happy also to answer any questions that folks may have. One quick thing that I'll throw out with this slide I forgot to mention is that I went to a MIG-DOS training a few months ago. The MIG-DOS is one form of assessment that can be used for autism. And I thought it was really interesting. Like she brought up some really interesting things. She uses the language of like unique brain style. I heard from another mentor, like she will make 2 different versions of reports. One that can be used within our medical model, like to give to maybe an insurance company or a provider for then certain accommodations or supports to be implemented because they need to see that certain type of medical language being used to get those services going. And then a report that's for the family that is providing some more just information about these learning differences and different things. So, yay. Okay. Awesome. Thank you so much. And let's see here. And then, yeah, we can also go back to the resource slides. Essay form and PowerPoint form. Awesome. Yes. And so I think that is like another reason to, right, kind of facilitate some rapport building for this to be like, to consider this as a therapeutic experience, right, is like gaining more comfortable. Like if a person feels more comfortable with a provider, they might not feel the need to mask so much. And that's important information for us. And then, okay, yeah, using the SRS. Yeah, the MIG-DOS training. If you look up, so if you type in Dr. Montero, her name is spelled M-O, I'll put it in the chat, Moteiro. She has a website. She does trainings. They were, for me, like a little out of my budget. So I was fortunate that my internship I'm on right now, they have like a fund for their interns for professional development. But it was a really cool experience. It was about 4 hours, I think, people from all over the world joining in on that, who are doing assessments, who are psychologists. Yeah, so I recommend, let's see. And then, yeah, just the SRS, you know, it's used pretty often in my experiences with assessment. I think one of its limitations is, again, the male and female. I also I'm not a huge fan of the qualifiers that they use on the measure, but it can be used to gather some useful information about different social domains. Oh yeah, thank you for putting that in that link in the chat. Okay. Yeah, happy to answer any other questions, and also recognizing that we're about at time. Thanks everyone who took the time to come out today.
Great. I want to thank you so much, Sarah, for sharing all that you have learned over the, oh my goodness, I think it's been like 6 or 7 years.
Yeah.
And when I hear you talking, it really makes me think back as what was common back then, and what's becoming more prevalent now. And it's reassuring to know that a lot of movement is being made in understanding and acceptance of neurodiversity. When I was in training, it was very much medical model.
Yeah.
So most of all my training and in my early career, it was all medical model, and that shift didn't happen for me until I started working with a lot of autistic adults, and that's where I learned the majority of what I know now. So not from textbooks, but from talking to the community. So, but it sounds like in your case, you're probably having to do a mix of both. I'm thinking that those principles are working their way into curriculum, but usually with education, it does take some time. So we end up having to really connect with community to figure out how to best understand and help people, because the prior ways were, it was a mixed bag, mixed results. So so glad that you're here talking about this today.
Yay, yes. And no, I think I attribute that, like the knowledge I have as of right now, I attribute that to mentors who are, leaving some of the old ways behind, including you. And I think just, yeah, having some more openness and getting opportunities to talk to community members has been like the ways that us providers should continue to gather information. So yeah, thanks for the opportunity today, Dr. Joe.
Great. Thank you, Sarah. Well, if anyone else doesn't have any questions, then we will end on time. And I thank you all for joining us on this Friday evening. And we got to do this again, Sarah.
Yes, for sure. Happy to come back to Project Casey at any time.
Welcome back anytime.
Yeah. All right.
Good night, everyone.
Take care. Bye.